Welcome to this podcast from the Medical Journal of Australia. My name is Sally Block, the MJA's news and online editor. The MJA acknowledges the traditional owners and custodians of the land on which we live and work across Australia. This podcast was recorded on the lands of the Wangal people. I pay my respects to their elders past and present. With the proliferation of GLP1s globally, a new study published in the MJA aims to provide an estimate of the number of adults eligible for TGA-approved medicine for chronic weight management. At least 4 in 10 adults are eligible for the drug and hundreds of thousands are eligible for the treatment of secondary prevention of heart disease. Co-author and PhD candidate Jasmin Castrillon joins me now. What prompted you and your co-authors to study the number of adults eligible for TGA-approved use of GLP1 RAs for overweight and obesity?
Yeah, thanks, Sally. This is a very fast-moving space. Overweight and obesity really affects so many Australians, and we often think about obesity in terms of body weight, but it's much broader than that. It can have a real impact on people's quality of life. It has broader health impacts, often linked to chronic diseases. And then if you zoom out from that, there's the impact on the health system and society more broadly. So there's been so much interest in recent years in finding better ways to prevent and treat it. And the rise of the GLP medications are definitely changing, I believe, the conversation on how obesity is treated. GLPs have produced much greater weight loss than seen than earlier medications and other lifestyle interventions. So for some people, they're also shown to reduce the risk of serious cardiovascular events. So GLPs were given the green light by the TGA for adults with overweight and obesity and the secondary prevention of cardiovascular disease after proving safe and effective in a series of clinical trials. And as all this interest was growing, we realised that there is one really basic question that nobody had answered for Australia, and that's how many people are actually taking these medications, and specifically under the TGA-approved indications. So that's really what we set out to do for this study. Sounds like it's quite a simple question, but it's actually something really important, as it's very difficult to, understand future demand and inform discussions about healthcare planning if you don't know the size of the population you're actually talking about. So I guess our study provides that piece of the puzzle. It doesn't answer every question, but it gives us a clearer picture of the scale.
So tell us about the study itself. What did you find out about the number and who is eligible for GLPs for obesity in Australia?
Yes, so we use data from the National Health Survey. So this is a large survey run by the Australian Bureau of Statistics. It includes information from more than 13,000 households across Australia, covering things like people's health conditions, their weight, and other background information. So we then looked at who would meet the current TGA approval for 2 of the current uses of these medications. So that's chronic weight management and reducing the risk of cardiovascular events in people with existing cardiovascular disease. We also explored a range of potential coverage scenarios based on different BMI thresholds and whether people had obesity-related health conditions to understand how those potential policy choices could affect the number of people who might be eligible if these medications were to be subsidised for certain subgroups. And what we found from the study was that the numbers are much larger than people might expect. We estimated that almost 40% of Australian adults, which works out to be about 7.8 million people, would be eligible to use a GLP medication for chronic weight management. And we also found that more than 330,000 adults would be eligible under the cardiovascular disease indication.
Right, that's a big number.
Yeah, well, as you can see, the numbers are quite large. They really highlight how relevant these medications could become in Australia. An important distinction to make, though, is it's just because almost 4 in 10 Australians are eligible, it doesn't automatically mean that someone should receive treatment, simply means that they could be considered. Decisions about treatment are a lot more individual than that. They depend on a person's health, their individual preferences, potential benefits and risks, and discussions with their healthcare team. Our study doesn't answer who should be treated. It just answers the question of how many people currently meet TGA-approved criteria, providing a policy-relevant reference for healthcare planning, future coverage decisions, and future economic evaluations. So I think as more evidence emerges, and it is emerging quite quickly, potential public access path, and as some public access pathways start to evolve, understanding the size of the eligible population becomes increasingly important.
So what sections of the population may be eligible for these medications?
Yeah, so one of the things that really stood out to us was that eligibility isn't spread evenly across the population. We found in our study that adults over the age of 45 were more likely to meet the TGA criteria compared to younger adults. We also found that among people already living with a weight-related condition like type 2 diabetes, high blood pressure, high cholesterol, and around 2/3 of adults with that weight-related condition would meet TGA criteria for chronic weight management. And then I guess another interesting finding was that eligibility was higher among people living in lower income households, with nearly half meeting the criteria for these medications. So, people who are more likely to be eligible may also often be the same people who already experience a greater burden of obesity and its related health conditions.
So how are people from low-income households disadvantaged when it comes to access to GLP-1s?
Yep. So when we talk about access, I guess it's important to remember that being eligible for a medication doesn't necessarily mean that someone can access it. For people living in low-income households, cost is likely to be one of the biggest barriers, particularly when these medications are not subsidised. The out-of-pocket costs for GLPs can be substantial, with private costs varying, but ranging from several hundreds of dollars per month. So for people, that ongoing costs can make treatments difficult to afford. They can also be barriers. There can also be other barriers beyond cost, like being able to take time away from work for medical appointments, having consistent access to healthcare providers, or just navigating the healthcare system. So there is a potential mismatch where the people who could have the greatest benefit from these treatments are also the people who face the greatest barriers to getting them. So I think that's why access and affordability are really important considerations as the use of these medications is expanding. And that's also why understanding who is eligible is an important part of this conversation.
How did you classify eligibility in adults that were included in the study?
Yes, so we based eligibility on the current TGA approved indications for these medications, which also closely align with the inclusion criteria used in the trials, which established their efficacy and safety. So for chronic weight management, this means people with either obesity or overweight and one or more weight-related comorbidities. And then for secondary prevention of cardiovascular disease, this means people without diabetes who have overweight or obesity and have established cardiovascular disease, so either a prior heart attack, stroke, or peripheral artery disease. So we then applied these criteria to the national representative sample of Australian adults to estimate how many people would meet the current eligibility requirements. And then we also looked at the potential coverage scenarios among adults who meet TGA approval, or you could say have been given the green light to potentially access treatment.
So what inspired the rationale for breaking population eligibility down even further into potential coverage scenarios?
Yeah, thank you. So there's been a lot of discussion globally about these medications and how they might be publicly funded for obesity. What we did was we looked at some international examples of how countries that subsidize these medications usually define eligibility. And we saw that a lot of them are using clinical criteria, most commonly BMI together with one or more obesity-related comorbidities. For example, in France, they've recently introduced reimbursement for people with severe obesity, meeting specific BMI and comorbidity thresholds. In Australia, the PBAC also looked at similar patient subgroups when considering GLP medicines for PBS listing and have highlighted the need to consider equitable access. While not added to the PBS yet, Wegovy or semaglutide was recommended by PBAC late last year for reducing cardiovascular risk in adults with established cardiovascular diseases and severe obesity, showing us that different clinical populations may be considered for funding. But also taking into account the evidence on clinical benefit, their cost effectiveness, the long-term health outcomes, and overall budget impact. So I think that broader context really inspired us to model a range of potential coverage scenarios based on similar characteristics like BMI, obesity-related comorbidities, and established cardiovascular disease, to better understand how many Australians would be eligible under each. And it's important to point out that these recommendations aren't about who should or shouldn't receive treatment, but they're simply intended to illustrate how different eligibility criteria could affect the number of people for subsidised treatment and, I guess, primarily help inform policy and future budget planning.
So eligibility for these medications doesn't necessarily mean that treatment is appropriate for everyone. What are the different factors impacting uptake and need for accurate estimates on real-world uptake in Australia?
Yes, and that's a really important distinction. So our study estimates eligibility according to approved indications, not the number of people who will ultimately receive treatment. Actual uptake depends on many factors, including clinical assessment, again, patient preferences. They may have a contraindication to the medication, and prescribing practices. Understanding real-world uptake will be important because eligibility alone doesn't determine healthcare utilisation. To date, this has been something that's been quite difficult to accurately capture due to a largely private market for indications beyond diabetes. Although there was a recent study which found that there is a large demand for these medications outside of subsidised access when looking at PBS dispensing claims together with pharmaceutical sales data. So this means that future studies that examine how these medications are used in Australia will be very important for understanding trends in use, evaluating costs and long-term health outcomes, as well as identifying any equity and access issues.
So what is the need for future research on the budgetary impact of the different coverage scenarios you looked at in the paper?
Yeah, that's an important question. I would say there is absolutely a need for understanding the budget impact of these coverage scenarios and potentially others as well. Beyond understanding the immediate budgetary impact, the evidence is still rapidly evolving. So research into long-term health outcomes of these medications, as well as the emerging therapeutic advances and real-world data will be very important for informing how GLP medications should be integrated into the Australian healthcare system.
And how will you be utilising your research to inform government about GLP1 use? And is there a need for people in lower income families to be subsidised further through the healthcare card system?
Yeah, thanks, Sally. So I think more than anything, the goal of our research is to be a useful reference for policymakers as well as for clinicians about the size of the population that could potentially benefit from treatment. This is one of the key building blocks for policy discussions around funding, workforce planning, and future health expenditure. In terms of lower income Australians, affordability is a very important issue. We know that obesity and many obesity-related complications are common in socioeconomically disadvantaged subgroups, yet these are often the people who face the greatest barriers to accessing effective treatment. And this is also very relevant to what the World Health Organization put in their recent guideline on the long-term use of GLPs for obesity. So they now recognize obesity as a chronic disease that requires long-term person-centered care. They recommended the use of GLPs where clinically appropriate, but also emphasized that medications should be part of a comprehensive care program for treating obesity, inclusive of other important lifestyle and behavioral support. They also warned that without deliberate policies, access could actually widen existing health inequalities because cost and limited availability, and specifically highlighted that affordability and equitable access should be priorities at the moment for healthcare systems and moving forward. So whether that means greater subsidies through the healthcare card or another funding mechanism, it's ultimately a decision for government, but we hope our findings can provide some useful information to those in policy about potential scale and implications about different funding options.
Thank you to my special guest, Jasmin Castrillon. You can find more podcasts on our website at mja.com.au or wherever you find your podcasts. Thank you so much for listening.